I'm allergic to dairy. I'm allergic to gluten. I'm allergic to onions. Gosh, I hear these statements constantly. And in many of these cases, what the person actually has is not an allergy at all, but it's an intolerance, which sounds like a minor semantic distinction, but it's not. The difference has real implications for what happens to your body, how we diagnose and treat it, and how restrictively you actually need to eat. I'm Dr. Karen Kaufman. Today we're sorting this out clearly and definitively. Here's the core distinction. A true food allergy is an immune system reaction. The most well-known type is an IgE-mediated reaction. Your immune system produces IgE antibodies to a specific food protein, and when you eat that food, the resulting inflammatory cascade can cause hives, swelling, vomiting, breathing difficulties, and anaphylaxis. The key features of a true IgE-mediated food allergy, well, it involves the immune system. Symptoms typically appear within minutes or two to hours of ingestion, and even a very small amount of the food trigger can cause a reaction. Now, this reaction is reproducible. The same food causes a reaction nearly every time, and in severe cases, this can even be life-threatening. But here is something important. Not all food allergies are IgE-mediated. There are immune-mediated food reactions that work through completely different pathways, and we will get to these in a moment. But first, let's talk about food intolerance. A food intolerance is a non-immune reaction and typically occurs in digestive tissue. So, for example, your body lacks an enzyme or the physiological capacity to properly process a specific food component. Key features of food intolerance, well, it does not involve the immune system, so it's dose dependent. A small amount may be tolerated, while large amounts of foods can definitely cause symptoms. Symptoms are typically gastrointestinal. They may include bloating, gas, diarrhea, cramping, and it's very uncomfortable. And sometimes it is extremely uncomfortable. But generally speaking, these are not life-threatening reactions. So here are some common examples. First, lactose intolerance. And this is probably one of the more common. And this is not a dairy allergy. So lactose intolerance means that your body does not produce enough lactase, which is the enzyme that breaks down lactose, the sugar in milk. The undigested lactose ferments in the colon, produces gas, bloating, and diarrhea. Now, a true dairy allergy, which is most common in infants and young kids, which many children will outgrow, involves an IgE response to milk proteins, primarily casein or whey, and it can cause hives, vomiting, and anaphylaxis. These two things are completely different. A person with lactose intolerance can often tolerate hard cheeses or lactase supplements, where a person with true milk protein allergy needs to avoid all dairy products and carry epinephrine as an emergency precaution. There's another thing that commonly gets mistaken. So non-celiac gluten sensitivity versus celiac disease versus wheat allergy. There is a three-way distinction here that is frequently collapsed into I'm allergic to gluten. But celiac disease is an immune-mediated reaction to gluten that damages the small intestinal lining. But it's technically not an IgE-mediated allergy. It's an autoimmune condition. And the treatment requires strict and permanent gluten avoidance. Non-celiac gluten sensitivity is a condition where people report symptoms with gluten consumption but test negative for celiac disease and wheat allergy. The mechanism of this is not fully understood, but it's not an IgE-mediated problem. On the other hand, wheat allergy is a true IgE-mediated allergy to proteins in wheat and can cause typical allergic symptoms, including anaphylaxis, and is one of the major food allergens. These are three different conditions with three different mechanisms and three different clinical management approaches. Very complex, and we deal with this stuff every day. Another one that we talk about all the time is histamine intolerance. So some people have difficulty metabolizing histamine in foods. Examples include aged cheeses, fermented foods, wine, sometimes fish. This can produce symptoms that mimic an allergic reaction, but it is distinct from a true allergy. Now, here's where it gets a little more nuanced. I said earlier that not all food allergies are IgE mediated, but there are conditions that are clearly immune driven that are real allergic diseases, but they do not show up on a standard allergy test or IgE blood test. There are some of the most misunderstood and underdiagnosed food-related conditions. The first of these is eosinophilic esophagitis, or EOE. We call it that to make it sound much easier. But EOE is a chronic allergic condition where the esophagus, which is the tube that connects your mouth to your stomach and is required for swallowing, becomes inflamed with a specific type of immune cells called eosinophils. This inflammation is triggered by foods sometimes, but it's not an IgE-mediated reaction. It's driven by a different arm of the immune system, which we call a type 2 immune response, involving T cells rather than IgE antibodies. These symptoms are different from a classic food allergy. Adults typically experience difficulty swallowing, food impactions in the esophagus, and chest pain, where children may present a little bit differently, sometimes with feeding difficulties, vomiting, or they have poor growth and fall right off the growth curve. Symptoms develop gradually over time with ongoing exposures, not within minutes of eating. But the most common food triggers when food is responsible are milk, wheat, and eggs. But here's the tricky part. Standard allergy tests do a very poor job of identifying which foods are causing EOE. Diagnosis requires an endoscopy with biopsies of the esophagus, and treatment can include dietary elimination, swallowed topical steroids, or newer biologic medication. EOE is increasingly common and is now recognized as a major digestive illness. If you have chronic difficulty swallowing or food impactions, this is something that should be evaluated. Another one of these non-IgE-mediated food allergies is something we call FPIES, or food protein-induced enterocolitis syndrome. FPIES is another non-IgE-mediated food allergy, and it's one that can look really terrifying. It primarily affects infants and young children, and in the setting of an acute FPIES reaction, the child will develop profuse repetitive vomiting 1 to 4 hours after eating a trigger food. And this can be really serious. These kids may become pale, lethargic, and even limp. In severe cases, they become so dehydrated that they can go into shock. There are no hives, no swelling, no breathing problems, which is why it's often mistaken for a stomach virus or food poisoning rather than an allergic reaction. The most common triggers in the US are cow's milk, soy, rice, and oats, food that are not typically associated with classic allergies because it's not IgE-mediated. Standard allergy testing is negative. Diagnosis is based on the clinical pattern, repeated episodes of severe vomiting hours after eating the same food with resolution when that food is removed. The good news? Most children outgrow FPIES by the age of 3 or 4. But until they do, strict avoidance of the food trigger is essential. And unlike classic food allergies, epinephrine does not help during an acute FPIES reaction. Treatment usually involves IV fluids and anti-nausea medicines, and sometimes even blood pressure support depending on the severity. Another really interesting food allergic disorder is something called alpha-gal allergy, which is due to a tick bite and relates to mammalian meat. So alpha-gal syndrome is one of the most fascinating and recently recognized food allergies. This is an IgE-mediated allergy, but it breaks several of the rules I just described. Alpha-gal is a nickname that's given to galactose, alpha-1,3-galactose, which is a sugar molecule found on the cells of all non-primate mammals. You do not develop this allergy from eating meat. You develop it from a tick bite, specifically in the United States and here in Virginia, the Lone Star tick. The tick bite sensitizes your immune system to produce IgE antibodies against alpha-gal. Then, when you eat the mammalian meat, which could be beef, pork, lamb, or venison, or in some cases, dairy or even gelatin, you may have an allergic reaction. But here's what makes it unusual. The reaction occurs delayed. Instead of happening within minutes, symptoms typically appear somewhere in the realm of 2 to 6 hours after eating. This is because the alpha-gal sugar is absorbed slowly and it's bound to fat in the food. Symptoms can range from hives to stomach pain to full anaphylaxis. Because of the long delay, many people and many doctors do not even connect the reaction to the meal eaten hours earlier. Diagnosis involves a blood test for alpha-gal specific IgE combined with a consistent clinical history. Management for avoiding mammalian meat and meat products and tick bite prevention become the mainstay. The encouraging news is that in many patients, the allergy can fade over time if they avoid further tick bites. Alpha-gal syndrome is extremely common here in Virginia and in other areas in the southeastern United States, and it's something every clinician and every patient should be aware of. So here's the question. What do we do about testing? Well, here's where it gets clinically important. Knowing which condition you have determines how we test and treat. For suspected IgE-mediated food allergy, we use skin prick testing and specific IgE blood tests. These identify whether your immune system has produced IgE antibodies to a specific food protein. A positive test means that sensitization, or your immune system making IgE to that food, may be present. But sensitization alone does not confirm a clinically meaningful allergy. The gold standard for diagnosis is an oral food challenge, where we give the food to a patient in a controlled and supervised setting and observe for the response. This matters enormously because a significant percentage of people who believe they have a food allergy and who have been avoiding foods for a long time sometimes turn out to not have a food allergy and tolerate it on an oral food challenge. Sensitization may be present from prior testing, but it's very important for the tests to be clinically relevant. Otherwise, the sensitization does not typically match. I saw a patient today with the same scenario. She came in with a list of many food allergies that were identified on prior testing, and I said, well, what happened when you ate these foods? And some of them she had never eaten before. So it's really tough, but it's important to do the right test. For conditions like EOE and FPIES, standard allergy tests are not typically helpful. EOE requires endoscopy and biopsy, while FPIES is diagnosed clinically based on the patterns of reactions and confirmed with a supervised oral food challenge when appropriate. Unnecessarily avoiding food is not cost-free. Nutritional deficiencies, social restrictions, anxiety around eating, and a lower quality of life are real consequences of an incorrect diagnosis. And on the other side, if someone has a true food allergy and does not know it, they may be eating a food that could really be harmful. Getting the diagnosis right is the entire point of all of this stuff. So here's the deal. Now there are increasingly more and more allergy tests that are available to do at home. And I want to address this specifically because I see it increasingly, patients coming in with results from at-home testing or even non-validated testing that are being ordered by non-board certified allergists. And this can include IgG testing for food allergy, hair sample analysis, applied kinesiology, and other similar products that are marketed as food sensitivity panels. These tests are not validated for the diagnosis of food allergy. In fact, IgG antibodies reflect food exposure, not an allergy, and typically the highest results are the foods that were consumed most time proximal to when the test was drawn. And it does not mean you're allergic or you're sensitive to it. These are very common. Please do not use these tests to make decisions about what to eat. Come see us instead. We will instead use validated diagnostic tools and clinical judgment to give you a much more accurate picture. If you have been avoiding a food for years because of a suspected allergy and you've never had formal allergy testing, or if you are experiencing symptoms after eating and you want to understand whether they are truly immune-mediated or not, come and see us and request a new patient appointment. The link is in the description below. We offer comprehensive food allergy testing and oral food challenges for pediatric and adult patients in Northern Virginia and the DC metro area. Thank you so much for listening. Next week, we're going to talk about pollen. If you live in the DC area and you have allergies, you're going to want to see this one. So make sure to bookmark this playlist and subscribe. Thanks again. We'll see you soon.